we're going to start with this chronic pain model, which isn't the best, but we're going to use this as one of our ways of understanding how chronic pain works. And we're going to talk about other types of pain that will be important for you to kind of just keep in mind and remember. So this idea of chronic pain is that there are several things that contribute to pain, and that's this circle right here, pain sensation, our experience of pain. And although this isn't a complete image of everything, this is a good start. So tissue damage can, of course, cause acute pain and chronic pain and flares. It could play a role in all of that. But the way in which it produces pain is through the nervous system. And that's something that we're going to go into in just a little bit. And just in general, keep in mind all of these other things and how they will produce pain also is through the nervous system. And of course, in how it does that is a little bit complicated. We're going to get into some of that. It will be helpful for you to know. And you already know some of this. So, one thing to just kind of keep in mind when it comes to acute and chronic is that acute pain is usually proportionate. So the more damage you have, the more pain you experience. This is how almost everybody thinks of pain. And what happens is over time, there's a lot of changes to the nervous system that if you've had pain for enough time, then you develop chronic pain. And this is because your nervous system is changing. And there's some theories around this. There's the gate control theory, which we've talked about, and central sensitization, which is similar. And essentially, what's happening, the basic idea is that as the nerves go into the brain, or as the signal goes into the brain eventually changes its behavior over time. And that's when we get into this idea of chronic pain. And when it comes to chronic migraines, we're going to talk about that specifically today and how you can understand exactly what's happening and have less of that. Okay. So as a basic understanding, we should go off of the kind of most fundamental part of the nervous system, which is the neuron. And of course, the most important thing for you to know and remember is that the neuron is really a chemical communicating device, and that these chemicals are connecting to these receptors, and those receptors are activating the neuron. And we can see that in this video here. So this video shows, we're zooming in on somebody's brain, and we're going to look at this specific neurotransmitter, but for the purpose of this, we don't have to know what it is or what it does. But essentially, we go in and we see that this is true for the brain and also for the body, that there's a lot of neurons that are communicating, and sometimes there's 3 of them together. And this is going to be important for us to understand why there's 3. So here you have, let's say this is the neuron coming from the body and going into the spinal cord. It's going to release these chemicals in order to communicate, and then those chemicals will attach to these receptors, activating this neuron, and then that neuron will send another signal to the next neuron. And so to really explain this, there's this nice little image here showing a nociceptive nerve inside of a thumb, and the receptors, which are on the neuron, as we just saw, they detect heat as well as temperature, or as well as chemicals, I should say, as we saw there, and of course coldness. And so once they've been activated, if enough of them are, you're going to see this signal. And the signal that goes into the spine, this is the spine, this is a side view of the spine. It's red going in, but it's yellow as it travels up to the brain. And the reason they're showing that is because what happens here is the chemicals are released onto the next neuron, and then this new neuron sends a different signal. And this is important to understand because this is exactly what we're seeing in this image here in some ways, is that it's sending a signal. I'm going to have to fast forward a little bit. it's sending its signals just like this. The chemicals will attach to it. It works a lot faster than that, of course. And this image, I want to show you this as well. Okay, so this is the same thing, essentially. You have the skin has nociceptors in it, and it has an upward moving signal that goes into the spine and synapses onto a new nerve. That synapse then travels up to the brain. If this process happens for more than 3 months, the behavior of these nerves change because, as we can see here, there's a downward moving nerve that comes back and communicates in order to send a signal back into the body to tell the blood vessels to do something, or the muscles to do something, or the immune system to do something. But it also then loops back around to communicate back with this little area. And we can kind of see that here. It's really blurry, but essentially the brain has a signal that comes back down, and then it interacts here. So you can kind of think of this area as like a junction where you get off of one train and get onto another to get to your destination. You have to get off of this neuron and go onto another one. And there's this nerve coming from the brain that can interact with that and influence it. And this is where the gate control theory comes in, and this is where central sensitization comes in, which are important to understand. And we're going to use these to understand how to have less migraines. So essentially, the brain can send a chemical down that would amplify this signal, so that if this signal coming from the body is a 2 out of 10 pain, and it should be sent to the brain as a 2 out of 10, this downward signal can tell the communication to become amplified, or to become de-amplified, or to completely close the gate, right? To open or close the gate, to allow the signal to go through, to not allow it to go through, to increase how much goes through, or to decrease how much goes through. And this usually only happens after the signal's been going for a while. And especially for several months, if you've had migraines for a long time, like you've had, then we're going to see that there are absolutely changes going on in the spinal cord and then also in the brain as well. And you've seen, I think I've shown you some of the gate control stuff. The idea is that there are some things that can cause this to increase the incoming signal from the body and decrease that signal. And in the case of migraines, this is coming from the trigeminal nerve, and as it goes and communicates with your brain, there will be a process of synapsing in which those neurons can increase or decrease the signal. And the reason that it's happening is chemicals, right? So this chemical comes down and it acts on this area and it will change that. And so anything that will increase or decrease your pain is because of chemicals. And that's why the sumatriptan, or however it's pronounced, what it does, it basically inhibits a chemical called CGRP. And CGRP is a very inflammatory type of peptide that does a lot of different things, actually. It has to do with like digestion and even moderating heart speed, and it does different things in the brain. It has lots of different purposes, but it also helps with the transmission of nociception and with pain, and it can increase that process. So thinking, okay, well, too much of this chemical is causing headaches. Well, how do I reduce it? The pharmaceutical companies are making drugs that can help with that. There's also, like we've been talking about, all these other things that we can do to reduce that process. Okay. So, as we see here, just to summarize, in the spinal cord, there is the nerves from the body that are communicating with the nerves in the spinal cord, and then there's a nerve from the brain that kind of moderates their behavior, and sometimes it will release a lot of these chemicals that will increase the signal transmission. And here we can kind of see where all of this is happening, as I think you've seen this as well. Okay. Another way of visualizing this idea is in this video here that nicely shows this pain threshold. changes. Actually, let me show you something else before that. Okay. So I don't think I've showed you this. Maybe I have, but this is trying to explain when a nerve in the body is activated and how it responds after it's activated. So neurons in the body, they have a certain level of electrical excitivity, how excited they are, and they have a baseline. And that baseline, it can be increased. There can be more electricity if there's certain things that stimulate it, like pressure or temperature or chemicals. And once it gets above a certain threshold, the nerve will turn on. So before that, it's not technically on, even though there's electricity in it. The electricity has to go over a certain point, and then the electricity goes much more, and then it fires, and then it sends those neurotransmitters on to the next neuron. And so you have to go above a certain threshold, and some type of stimuli has to push you above that threshold. 1 in 4 people, according to this website, they're saying after you've had some type of injury, that threshold or the sensitivity of the nerve or how close it is to that threshold gets modified. So basically, before you have some type of injury, and in the case of an injury, it will be a good example, and we can then compare this to migraines. Your nerves are less active, or they're turning on less often, or they're less sensitive to stimuli like walking or moving or pressure. And it will take quite a bit of movement or pressure or temperature before they go above that threshold and turn on, and then you would feel pain. After, there's about 25% of people, their nociceptors don't actually return to their original level, and they have this extra sensitivity. And so for a variety of reasons, this happens, and the amount of room for activities and pressure and temperature ends up being so little that even the slightest amount of movements and things like that can trigger this. And so the kind of one of the main takeaways is that in chronic pain conditions compared to acute pain, the nervous system changes and becomes more sensitive so that nerves in the body are turning on more readily because they're closer to the threshold of turning on. And the reason this happens is chemicals. And then when they synapse onto the spinal cord, if this happens enough, will change its behavior and it will amplify the signal. And then when the brain gets that amplified signal, it then sends a signal back down, and it can either de-amplify it or amplify it even more. But what's important for us to know is that the brain associates that stimuli and that experience with other outside and internal cues, and it starts to associate things together. And when the brain starts to have this association process, that's when we get really stuck with a whole host of different chronic pain conditions, and migraines is a really good example of that. Okay, so that's kind of a quick rundown of why acute pain turns to chronic. It has to do with how the threshold changes and the sensitivity of the nerves in the spinal cord and in the brain end up changing. So I think we're going to maybe just step back a little bit and talk about some other more basic things. Before we move on, I just actually want to kind of point something out here. I'm not sure if it was here or somewhere else. Okay, so here they're basically saying that CGRP causes intense inflammation in a layer of the top of the brain and is one of the main causes of migraines, and that a lot of work has gone into researching how CGRP causes pain and how they can try to reverse that process. And so when we think about CGRP as a neurotransmitter that transmit nociceptive signals, it's helpful to understand what regulates this thing, because this thing causes pain, right? And there's this medication that helps to reduce or decrease CGRP because it has an agonistic effect on serotonin neurotransmitter or something. However, if you're not taking this, or if you don't want to take it, then obviously, in your case, wanting to not take this, we have to figure out, well, what else is regulating this and how can we have less of it? And one of these things is TNF alpha, which is part of our immune system, or it's a response in order to help with our immune system. And there's other pathways as well. They're mostly neuroimmunological pathways. We're not going to be able to get into too much detail about this today, but in general, you just want to keep in mind that it's really the release of CGRP that's causing the migraines. And if you want to have less migraines, we need to have less of this. And how do we have less of this? We have to have less of anything that makes this or releases it. And those chemicals, and anything that releases those chemicals that release those chemicals, right? It's a chain reaction. And it comes back to biopsychosocial. So that's kind of where we'll transition to this idea of what is biopsychosocial, and back to this kind of onion-looking graph, and understand, okay, if this is the chronic pain model and it's the biopsychosocial model, how do we have less pain, and what is the role that it plays in reducing CGRP for you? So before you may be familiar with this, but it's always helpful to review. Before we talk about biopsychosocial model, we have to talk about the model that we used to believe, and that many people still believe today, about how pain is made and what regulates people's pain experiences. Right? So the general idea here is that pain is generated by the peripheral nerves, or the nerves in the body. They make the pain, and then the pain that they make is sent all the way to our brain. And then the basic idea here is that our brain only learns about pain. It doesn't make it. It has no role in it. That's what we used to believe. It's reasonable to believe this because it makes some common sense. The motto that goes with it is the issues are in the tissues. So the pain in the wrist is made by the nerves in the wrist and sent to the brain, and the brain learns. And if you have pain here, the amount you have is proportionate to the amount of damage going on. And if you still have pain after surgery, something is missed. And we really wouldn't ask you about anything that has to do with psychosocial stuff. We wouldn't want to know about your childhood, nothing like that, because this model, the biomedical model, just says there's something biological going on here, and that's the cause. Okay, so that's obviously not how it works. Let me see if there's anything else about that model that's important to know. The main things that are important to know are that we believe that the tissues here made it. We believe that the pain is proportionate to biological disease or damage or disorder of some type. So that the more pain you have, it has to be related to tissue damage of some type or more disorder, which also is not true. And I think there's one other main thing that they believe that's not true. I think the idea is that the brain doesn't play a role in it, therefore there could be no psychosocial factors that could influence it. Okay. So now, because of brain imaging research and other things, of course, we know more about how pain works. And so the biopsychosocial model has come about, which basically says the body tells the brain what happened. It only sends data. And then the brain decides how painful that should be, if it should be painful at all. And so what we see is that if you have pain in your wrist, there's a variety of ways that it could be made. The first way is that nerves in your wrist are turning on, and when they turn on, they send data to the spinal cord, and then the spinal cord hopefully sends the same data to the brain, and then the brain gets that message at the thalamus. And this is where it gets kind of interesting, and is worthwhile to look at some images of this. Hopefully I can find some. I know there's some out there. Yeah, these should do fine. Let's see if I can find one. Yeah, this should do for now. The spinal cord gets the message from the body and sends it up through the brain stem, which we see here. It goes through the reticular activating system, which is filtering out stuff. So it filters out any sensory data your brain thinks you don't need, like the sound of a plane going by or other things that are unnecessary, like the feeling of the clothes on your back. You don't need to know that. And if you have pain, that's going to be probably prioritized and get pushed through, and it will go to the thalamus. The thalamus is your control center of your brain. It's very important. It's basically it's like where all the signals of the electrical activity of your brain originate, and it sets the clock for the rhythm of your brain. And it's shown to be playing a role in pretty much all mental and cognitive disorders. So the thalamus is extremely important. What it does is it's connected to almost every part of your brain, and it sends signals out to them. This image doesn't show it very well, but it does show you some idea of how the thalamus sends signals out. So it can send it out to the prefrontal cortex. It can send it to the back sensory areas. It can send signals back to the cerebellum or to the emotional parts of the brain, like the amygdala. That's the fear part of the brain. And then those signals will come back eventually. They'll follow their same pathway down or similar pathways down back to the thalamus. And the thalamus gets information from those areas. Each one of these areas is specialized to do something. And the thalamus is the central control hub that takes all of that information and compiles it. Underneath the thalamus is the hypothalamus. And then underneath the hypothalamus is the pituitary gland. So the thalamus tells the hypothalamus everything it learned, and then the pituitary gland does accordingly. And so these all play a role in chronic pain. In fact, the entire brain plays a role in chronic pain. So when the signal comes in from the spinal cord, which already could have been changed and modified, the thalamus then takes that signal and sends it out to the brain, and then the brain determines how dangerous this is, the memory parts and the sensory parts and the locating where in the body it was, because some body parts are more important than others, and therefore if they're damaged, they're more dangerous to us than others. And the cerebellum has to do with balance and things like that. So all of this would come back to the thalamus, and the thalamus would have an idea of how dangerous this is, and then it would send a signal down, which they're also not showing, but I can kind of show you here. This here, they're kind of showing the thalamus, and this blue line will then come back down, and that's what this image shows in better quality, where the green nerve is the motor neuron that goes back to the muscles and back to the skin and to the blood vessels and helping to communicate to the immune system, so that the brain eventually ends up sending a signal back to the body in order to help you to move your hand away from the thing that's painful, or to have certain pain behaviors, or to release things that might cause more or less pain. Or maybe I should say chemicals that will influence nociception in the body. Right, so starting from the beginning, a nociceptive nerve is activated, let's say, because of pressure receptors in it when I cut my skin. My skin is cut, the pressure is changed because of that, the nociceptor turns on. It sends a data signal to the spinal cord. The spinal cord should send the same signal if this is an acute injury and I don't have chronic pain. If I have chronic pain, it might already modify that signal. And then my brain will then divide that signal up. The thalamus will divide all of that up, and it will very quickly analyze how much pain should be made for this paper cut. If it's a paper cut on my finger where I play an instrument, that might be more painful than a paper cut on a finger where I don't play the instrument. And so it'll send a signal back down, and that signal will change my motor behaviors, but that signal isn't necessarily pain. Pain isn't like a downward moving signal. As far as we understand today, pain is when your brain maps. Your brain has the body map, and it creates pain by firing a specific pattern linked to that map. So we'll just take a look at that. Somatosensory strip, just to really kind of have an image of this and a good idea of what I'm talking about. So again, we can see this red strip is the sensory somatic strip. There's two of them. One's for outgoing information and one is for incoming. We can see that here. Motor is outgoing, sensory is ingoing. And they're pretty much the same. They map your body for outgoing or incoming messages. So if I get a paper cut on my thumb here, then this part of my gray matter neurons will turn on. And I will feel the pain here because those neurons turn on. If they didn't turn on, I wouldn't feel that. If this part of my brain was damaged, I wouldn't even feel my hand. I wouldn't even know I had a hand. Or I could see it with my eyes, but I wouldn't feel it. So these neurons in this part of the brain is the only reason we can feel our body or feel anything. And our brain and the limbic system, or the emotional parts of the brain, are create emotions. So often we feel emotions in our body, and our body plays a pretty big role in that feeling as well. But our brain plays a very crucial role in emotions. So, but getting back on topic, the pain is going to be mapped to a specific area. So right here, we'll map it to this area, the hand or the wrist, wherever the paper cut was. And then it will turn on with other parts of the brain that are associated with pain. Like there's at least a dozen or so of them, and we can look that up really quick as well. That's called the neuromatrix model. It's also called some other things nowadays. Okay. Or also called neurotags. That's probably better. Okay, right. So here they've got 9 different areas. And so the idea is that pain happens when these 9 areas turn on at the exact same time. And number 1 is the part that we were just talking about, the sensory somatic area. So when this area turns on with those other 8 areas, pain is made. However, those areas rarely turn on by themselves. In some cases that may be true, and especially in chronic pain, that's far more common, that they're turning on irregardless of what the body is doing. So there could be no signal from the body, but those could all turn on at the same time, and you could have pain in your body when there's nothing wrong with your body. So this is less common. In your case, what I believe is happening is because of biopsychosocial stressors, inflammatory neurotransmitter CGRP is being released to protect you. It's a response to the stressors, which stimulates a nociceptive nerve here, the trigeminal nerve. Then that sends a signal into the brain, which activates a network in your brain that has been so well developed that it probably, as soon as it gets even the slightest hint that the trigeminal nerve is turning on, immediately turns on and activates pain, and it maps it on the forehead, which is right here, and it will map it there for you. And if your headaches ever grow and go down to the lower parts of your face, that just means your brain is starting to connect with other areas of itself when it's kind of mapping what we would call a network, right? Or a matrix. They call it a matrix. It's when different areas of the brain fire at the same time. And so this is kind of like really advanced brain stuff that we've recently figured out, is the way that the brain is figuring out information is different parts of the brain are sending electrical signals at the same frequency, and that's how they're communicating. Now we've talked about a variety of things, okay? We've talked about how nociceptive nerves in the body are activated by temperature, chemical, or pressures, and how they turn on, but they don't create pain. We know that there is a, it's called a ganglion, or the dorsal root in the spinal cord, can change or modify that, especially with the help of the brain, in which the brain can help to modify that signal and send that signal up to the brain. And then the brain itself can further modify that signal through this network called the neuromatrix model, in which when the signal gets in, the brain already has this network to be assigned to that type of signal, and it'll turn on more readily. And what we find is that if that signal comes from the body long enough, the brain creates such a strong network that it no longer relies on information from the body. It can rely on information from the environment. So if I reach my hand and I hurt it every time I do something, let's say I'm picking up my favorite coffee mug or something, and it's a white coffee mug, eventually, if every time I reach for that mug I have pain, my brain will learn that the mug and the movement and even the room or the kitchen or the color of the mug are all potentially dangerous, because color is in one area of the brain, the movement of the body is in another, the reaching for the cup or the color of the cup or the shape or the texture or the feel, all of those things are decoded by the brain and then organized together and put into your experience of the present moment. And if they're creating pain, if every time I do that it creates pain, your brain will start to think that those individual things may be dangerous, and in the right combination is dangerous, and eventually can become so well prepared to anticipate danger that it starts making pain even when the body hasn't sent the signal. Right? And this is what we call true central sensitization, or what I would call pure chronic pain, because sometimes you can have chronic pain that is also acute pain, and it gets very complicated. And that's true for most people, because people are just complicated. Our bodies are complicated. It's never just pure chronic pain. It's pretty uncommon in my opinion. Okay, so we know about the brain, the spinal cord, and the nerves in the body. So what we want to talk about a little bit is more about the biopsychosocial model and how that influences those three main areas that are helping to produce pain. So keep in mind, thoughts and feelings are physical things. They are electrical, magnetic, and chemical processes in the body. And that your thoughts, feelings, and behaviors or actions are all connected all the time. So when we say biopsychosocial model, all of these things influence essentially your biology. And so it's somewhat redundant to say this, but the biopsychosocial model is always a biology model, right? And there's a lot of confusion about psychosocial here, and I will help to clarify this now, but I think there's this stigma around it, and people believe, oh, psychosocial, then I must be making it up or it's fake somehow. But in reality, these things are measurable, physical, real things that are influencing your body and making real pain. So your thoughts change your biology. Your feelings, whether they're emotional or physical, they're your biology. They're your nerves and all the other things in your body, like your immune system. And what you do, if I move my body, that's going to change my body. If I run, if I walk, if I sit on the couch, if I eat potato chips, if I go talk with some friends, if I watch a comedy, all of those things will change my neurons. And if I do something enough, my neurons will get really good at that thing. And all of these things also influence each other. So that's the other thing, is that it's a matrix again, that they all kind of web together. So that if I go watch a comedy and I do it with friends that I enjoy, I'm going to be feeling more emotionally happy. I will have been more physical, and I probably will have thoughts that will be focused on whatever I'm doing at that moment. So this brings us back to the very beginning, which is that the chronic pain model is that tissue damage might be the original cause in some people's cases. It doesn't have to be, but just for this example to help illustrate, if I damage something, it's going to activate nerves. It's going to change my body. And just to really clarify, if I break my bone and my bone doesn't have nerves in it, I would not feel a thing, because the bone can't make feelings. And those nerves in my bone, they send a signal to the brain, and then the brain makes the feeling. So if there's ever pain or any feeling like joy or frustration, it's because your nervous system is playing a role, and your nervous system is just a bunch of chemicals mostly. Anything that you feel is because of the nervous system. So if it's joy or frustration, if it's emotional feelings like that, or if it's any physical feelings like texture, like rough or smooth, it's because of the nervous system. And the nervous system is just chemicals communicating neurotransmitters through nerve processes. So when we understand the most basic building blocks, which is the neuron itself, then we can start to understand what, and build up from there, what is the process of pain. And it's basically just chemicals that change the behavior of neurons. So if my bone is broken, then my neurons detect that, and they behave in a certain way, and they communicate with the brain, which changes how the brain behaves. And eventually a network of neurons in the brain will turn on, and I'll feel pain. So there should be another circle here that says nociception, because as soon as I damage my tissues, nociception is the next part, and then pain is the third part. And then when I have pain, I always usually have thoughts about this. Oh, I hate this pain, or why did this happen to me? And then there's emotions like frustration. And then suffering is kind of a separate quality than pain, in which we have suffering on top of that pain, right? For example, if I break my bone, but I'm right next to a hospital, I may not be suffering as much if I break my bone and I'm not near a hospital. Maybe I'm deserted somewhere. And the suffering comes from my fear and worry that I won't get help. And it's another quality. It's a different, separate quality than pain itself. However, the actual emotional experience of suffering will influence pain. So although these circles are like an onion, they can influence each other, so that my suffering can actually make my pain worse. And it could even make my tissues not heal as quickly in some cases. And then, of course, my pain behaviors, this could just be regular behaviors. So if I don't have pain and I sit on a couch all day, I may develop pain for a variety of reasons. If I do have pain and I start acting in certain ways, I could act in ways that make my pain worse or better. I could start screaming and looking at the injury and saying, this is terrible, my life is going to end. Those behaviors would probably amplify the signals in the nervous system for a variety of reasons, at the brain, at the spinal cord, and possibly even it could cause changes in the chemicals in your body, which would be another way of amplifying pain. Or I could have pain behaviors that do the opposite of all that, which is I'm going to be okay, I'm going to breathe nice and slow and deep, I'm going to know that people will take care of me, and that I'm going to recover and it won't be the end of my life, or that it'll be a good learning opportunity or something, right? Maybe I'll change my focus and I'll use mindfulness and other relaxation techniques, which will ultimately change nerve behavior in my brain, my spinal cord, and my body. And then lastly, the outside environment is, of course, all of those things like temperature and noise and the stress in the environment and my perception of the environment, right? That would probably go back to thoughts. This, of course, is not a comprehensive list, but it's just a nice way of understanding all of the biopsychosocial features that influence pain. Not just chronic pain, but also acute pain and flares. Okay, so I think we should talk a little bit more about biopsychosocial before we move on. Actually, we're kind of at time here, so we'll just wrap up with the idea of the biopsychosocial model. And then we'll kind of summarize everything. Okay. Oh, I wanted to come back to this really quick. So there's this version which shows that the threshold is closer. And then this is a similar way of thinking about it, which I think you've seen before, which is that whenever the nerve goes above this line, it turns on. And here it's showing that it's turning on more. It's the same basic idea, is that the pain threshold is lower. And here it's like saying the nerve activity is higher. Or you could just also say the firing level is lower or closer, and therefore the nerve is more likely to turn on. And we could see this in the body, we can see it in the spine, and we can also see these types of behaviors in the brain. And so if nerves are more likely to turn on that are pain networks, then you're more likely to have pain regardless of whether you have actual damage to your body or not. And one of the important things to take away from what we're talking about today is that if you've had pain for a long enough time, then your body builds in brain networks that act on the nerves in the spinal cord and act in ways to continue to amplify and increase the pain experience, the frequency, the severity, and the length of the pain outside of actual changes to your biology or biomedical problems. It's just the nervous system rewiring and getting better and better and more efficient at producing pain. Okay, let's look at this one. Okay, so this also probably isn't exhaustive, but it's a nice look. Your pain experience is influenced by many things. Tissue health is absolutely one of those things. If I cut my skin, then of course nociceptors will turn on. And the neurochemistry plays a role in that. And the physiology, how healthy my nervous system is working. My genetics, do I have a genetic abnormality that stops certain nerves from turning on? This is something that happens to some people. And then any of these things that are psychological or social, you want to keep in mind, it actually is influencing our biology. And that's kind of why we call it biopsychosocial, but it's always biological in the end. Because if I have social learning, people in my environment telling me that I'm having pain because I'm a bad person and I deserve to have pain, then that's going to teach me that I'm a bad person and I should feel guilty, and I might feel guilty and angry, and then I might even become depressed. And all of these things, these emotions, are chemicals that are, of course, changing my neurochemistry. So everything will always come back to this area, to physiology and neurochemistry. It doesn't necessarily come back to tissue health, because tissue health goes back to that. So I'm going to probably eventually end up creating my own versions of all of these, because none of these I think are sufficient in really helping people understand the complexity of pain. The last thing I just want to point out here is something very important, which I've mentioned a few times, is that there are classical conditioning and operant conditioning reasons for, or ways that the nervous system works. In fact, the nervous system is like an operant type machine in which it associates things together. I think we can get into this next week a little bit more, because this is very important. But the main idea is that eventually your brain starts to no longer require the original stimuli, and it only requires the thing it's associated that stimuli with in order to produce the physiological changes that the original stimuli produced. And so, for example, if when I see my favorite food, I start to salivate, but every time I see my favorite food, I also hear my favorite song, eventually just listening to my favorite song will cause me to salivate, which it normally would not do unless it's been associated with my favorite food. And so this is exactly how chronic pain works, in that eventually with the migraines, there are like cues or indicators in your environment or in your internal environment, your body, your brain, your mind, your emotions, that have been associated with pain, maybe for the good reason at some point, but for whatever reason are still there, and it's strengthened in their network in your brain. And then whenever that thing is presented to you or becomes strong enough, it will activate in a cascading effect all those other networks and basically turn them on, and you'll experience pain. And when they turn on, by the way, it's going to release that CGRP. So ultimately, we need to figure out what's releasing the CGRP, or just to think about it or say it in more simple terms, what's causing inflammation of the trigeminal nerve. And those things could be food, but they could also be operant conditioning type things that are less direct, like food, or less direct than tissue damage. Something like color or temperature, or more likely stressors. But certainly things like color and temperature would play a role. Okay. even in acute pain, your brain can change all of these things. So all of this sensitization we're talking about, it does happen over time, but it can also happen immediately if there's enough information to cue the brain to do so, right? For example, if I get a paper cut with $1 million lotto ticket, do you remember that example? The brain will produce opioids and other like epinephrine and other neurotransmitters because how excited I am about that money. They will actually end up being released onto the synapse here and closing the gate from here and stopping that signal, versus the other scenario is it's a parking ticket and I'm pissed off and that chemical changes it as well. So, however, when you have migraines for a very long time, what we're seeing is likely the brain is somehow picking up on some cue either from the body or from the environment outside, and it's then producing inflammatory responses and pain. And it's hard to maybe even pinpoint, is the pain being produced and then inflammation as a result of that, or is the inflammation being produced and then pain as a result of that? It's likely a combination somewhere in there. The one other thing just to keep in mind is something we pass over quickly, and I know we talked about it, but I just want to reiterate. The nociceptors don't send pain, and that what you want to know about that is pain is produced based on evaluation by your brain, evaluating not only the nociceptive signal, but many other signals. So if you have nociception on the trigeminal nerve, your brain hasn't made pain yet. It has to evaluate that. And like I said, your brain probably gets the slightest hint of that turning on and makes pain. But eventually, we might be able to get you to the point where even if your trigeminal nerve is inflamed and turning on, you may have no headache if your brain can evaluate it as something that's not to be considered dangerous and to not activate pain pathways. Mm-hmm. And that would happen through exposure, and basically you would be doing operant conditioning stuff that would reverse the process. It would unlearn the process, and that may take time, and it may be troubleshooting how to do it. Sometimes we might not figure it out right, but it's possible.